Hello, I'm Graham Newstead. I'm a colorectal surgeon, head of colorectal surgery at Prince of Wales Private Hospital, and I'm pleased to have the opportunity to talk to you. It's a pretty mundane, basic topic that I've been asked to talk on today, but I just thought I'd give you a few wrinkles that might be helpful to you in your general practice from a bit of experience playing with bottoms over the years, and point out some of the little tricks I've learned and some of the things you might consider when you're dealing with your patients. I'm going to talk about hemorrhoids in a bit more detail at the end, but I'm going to use just a couple of simple slides and just talk and explain, because you've all seen bottoms and fissures and fistulae and hemorrhoids and things on many occasions. I just want to talk about some of the things, as I said, that I've learned that may be of some benefit to you in your assessment, your decision making and your management. So firstly, this is really simple. I mean, this is medical student stuff. And I haven't put that in such a simplistic form for the apparent reason. I put it there because I think most of the time, without getting off our backside, we can actually determine by quizzing the patient where the blood's coming from. And I don't think it's really adequate purely for you as GPs to be able to decide, are you going to hand over a cream? Are you going to send a patient somewhere? Are you going to order a colonoscopy or whatever it is? Excuse me. You should be able, by talking to your patient, to nearly always erring on the side of safety, but nearly always get right the origin of the blood. So, I've got some bleeding, doctor. How long have you been seeing the blood? Where do you see the blood? Is it on the paper only? Is it in the toilet? Do you actually look in the toilet to be able to answer my question? You won't ask it like that, but you were thinking to yourself, does the patient understand what I mean? Do you have blue loo in the toilet? Because if so, please get rid of it, because you can't really tell if there's blood in the toilet. Hemorrhoidal bleeding is blood on the paper, blood coating the outside of a motion if it's a formed motion, not a runny motion, because if it's a loose motion, you can't tell if the blood is mixed with the motion, if it's in the toilet, or coating the motion. Is there any bright blood splattering the dry white toilet bowl? In America, you wouldn't know, the water's up high. In Australia, it's down low. Are there any splatters of blood in the toilet? Do you get pain with your bowel motion? How much blood is there in the toilet? Are your bowel motions normal or abnormal? Are you constipated, or do you have the reverse? Do you have multiple loose motions in a day? If the bleeding sounds to be of outlet origin, you can then cut down a little bit on the number of diagnoses. Patients are not aware of how we form bowel motions. It's weird, but they don't. So I do a quick, we eat with them. We eat, I've got a diagram of the belly. We digest, point to the stomach. And then go down to the small bowel. We complete digestion, and then point at the end of the small bowel, we absorb all the good stuff from our food, goes to the liver, point to the liver. The rest goes into the pink area on my diagram, colon, and it's liquid waste. And yet we produce usually formed waste. How do we do that? Water gets sucked out round the bowel, so we have a snake moving it round, and we have a water filtration plant. And as the water's sucked out, we store our motion not in the rectum but in the sigmoid. The sigmoid is empty, the rectum is empty till the sigmoid is over full. And when it's over full, it drops it into the rectum. The rectum is yay wide, but gets narrower, pinched by the pelvic floor muscles just above the anal margin. And because it's narrower there, it sends a signal for the internal sphincter, the muscle you and I can't control and works automatically, but keeps me shut at rest. And then that muscle relaxes, but because I'm not a cow in the field, it's not appropriate for me to evacuate where I am, so I voluntarily squeeze my external sphincter till I can get to the loo. I sit down, I relax that muscle, and that exposes the already relaxed internal sphincter, and I can evacuate. Now that is relevant to explaining hemorrhoids, fissure, fistula to a patient. So, if they've got hemorrhoids, motions are all right, maybe constipated, maybe a bit of blood coating the motion, maybe a splatter in the toilet. It's of local origin. How old's the patient? If they're 65 and not sure about the blood in the toilet, or it always seems to be in the toilet water, and I don't think I've ever seen it in the white toilet bowl, or I don't look, then you may have to have some form, or you carry out some form of more proximal assessment to the anorectal outlet. If they're positive and they say it's definitely separate, I have a motion but the blood is splatters only or only on the paper, then you can be pretty comfy it's of local origin. You could of course have a rectal cancer sitting just above the sphincters, but that's going to be unlikely because they're probably going to have a feeling of incomplete evacuation or some other features that might make you twig. And if it is only just there, your finger in the bottom is going to feel it anyway. For a fissure, I often get patients, by the way, just going back to hemorrhoids for a moment, please see rectal bleeding and anal pain. Anal pain from a hemorrhoid is as rare as rare. Hemorrhoids are not painful. Incarcerated, prolapsed, fourth degree hemorrhoids, of course, are painful. But I'm talking about the average, I've got a bit of bulging at the anal verge, or you look and they've got bulging skin components, but nothing else to see, and your digital examination is normal. You won't get pain from a hemorrhoid from that. You can also have outside the anal verge a blue, acutely painful bulge, different matter. So go back for a moment to the fissure. They're painful. If you don't have pain, you don't have a fissure either, or are unlikely to, or you don't need treatment for it. Because a fissure is a tear in the most distal part. Nature's good to us this way, they're almost always distal. In the anal verge, the majority of which are posterior midline, some are slightly posterolateral, and some are anterior, but mostly distal and mostly posterior midline. And they're always painful because there's a tear, and most of us will get a little tear at some stage due to hard motions, no big deal. They get better. And a bit of ointment or nothing will let that settle. But if you're unlucky enough to get spasm in the exposed internal sphincter, then the last thing your internal sphincter is going to want to do is to obey the anorectal inhibitory reflex, which occurs when that rectum gets full at its most distal narrowed end and your internal sphincter is told to relax. It says, I ain't going to do that because I'm not going to hurt my owner more. So it stays tight. Now eventually the owner has to go to the loo, but does so against an incompletely relaxed sphincter. And what gives way? The line of least resistance, which is the tear. So it tears more. So you've got two vicious cycles: tearing, spasm, tearing, spasm, tearing, trying to heal, tearing, trying to heal. And the trying to heal is heaped up fibrous scar tissue. It's granulation and then becoming epithelialized scar tissue, whilst the centre with the exposed internal sphincter fibres keeps tearing, granulating, etc. So there comes a point where you just cannot get scar to heal to scar, but you can get poor healing as proud flesh, granulating tissue at the apices, proximally or quite commonly distally, and that's the dentate line papilloma proximally, or the sentinel tag distally. And if you therefore have your patient with a quite prominent single tag that doesn't look like loose skin as hemorrhoidal bulging skin will look, but looks like a tag, then that's possibly a fissure. And that's a no-brainer. Finger in, spasm. There are 3 degrees of spasm in Newstead's classification, and I call it Newstead's because it's not very clever. First degree spasm is when there is some spasm more than the internal sphincter should be tight. Second degree is when it's hard to get my finger in, it's painful for the patient. And third degree is when it's so tight the patient won't let me put my finger in. And I'm good at putting my finger in bottoms because I do it all day, every day. So I can be gentle with it. So that's first, second and third degree, nice and simple. And you can discern then whether the patient's got a significant fissure, and you can palpate it. And if you push your finger in, they say ow straight away, you can feel with the pulp of your finger posteriorly that there's a gap there, a crack, and they say ow. You push your finger forward on the sphincter and it hurts a little less for them, then you know that they've almost certainly got a fissure, and as I say, without even putting a proctoscope in. So you can make that diagnosis too. Fistula's a no-brainer. You've got a sinus externally. Nearly always you can get distal intra-anal internal openings with proximal internal openings as a fistula, but they're nearly always external. And you can possibly not discern whether the bleeding is higher rectum, such as from a cancer or a big polyp. And that needs the at least sigmoidoscopy, rigid in the rooms, or colonoscopy, flexible sigmoidoscopy, colonoscopy. Colonic hemorrhage is melena, or somebody who you know has got ulcerative colitis or comes in with their first episode and they've had 20 episodes of diarrhea every day for the last week with mixed blood. They're off to be sorted out straight away. So you can actually ascertain by and large the likely cause, or at least the geography of the bleeding. So the sort of questions we asked before: pain through the anal canal, you can almost work out the amount of spasm in the internal sphincter by asking, is the pain during or is it just at the end? If it's during, they've got an acute, active, painful fissure. They're like this on the toilet, and they want to try to break up the motion, because if it's a form motion, and particularly if the cause is constipation, and they've torn before and they're still passing hard stools, if they tell you that as they're passing the motion on the toilet, you need to ask them this, do they try and break up the motion into segments, squeezing their external sphincter and breaking it up to try to minimize the discomfort? Or some will say the reverse. Oh, I wouldn't do that. I just try to get it all out and bear the pain till it's over. But both those answers will give you an indication that, yeah, this is likely to be bad second or early third degree spasm. And that's helpful too. Don't let patients, and don't you call a tag a hemorrhoid. A hemorrhoid is covered by mucosa. You can prolapse the dentate line and thus have external skin component and external mucosa with dentate line external in 4th degree prolapsed hemorrhoids. But skin at the anal verge, patients will regularly cause hemorrhoids. Why are you here? I've got hemorrhoids. Are you bleeding? No, blah, blah, blah. I just don't like these hemorrhoids on the outside. And you look, and they've got skin bulges. Small tags left after dealing with hemorrhoids are often not a problem for patients. It's the fact that when they go to the loo, they bulge. So another question is, tell me, when do you get your external bulges? Are they there all the time? Either, yeah, they're there all the time, or that's only been for the last year, or it's been forever, or they only come out after I've finished a bowel motion. Okay, what do you do with them? Do you push them back, or do they retract spontaneously, return spontaneously? And that's important too, because you've then got an idea of whether you're dealing with 2nd, 3rd or 4th degree hemorrhoids. Remember that the vast majority of hemorrhoids today can be dealt with by simple office procedures, and we'll come to that. So once you've assessed on history, and once you've assessed with whatever tools you A, are comfortable using and B, have available to you in your practice, be it a digit with a glove, be it a proctoscope, be it even a rigid sigmoidoscope, perhaps not so common these days in GP surgeries, but still. Once you've assessed the history and have got in your mind what you think you're likely to find, and then you have done the amount of examination with which you're comfortable, you are then in a position to know what to do with your patient thereafter, be it soothing ointments, be it a pharmacological ointment for a fissure that you've put your finger into and felt it, and they're not too bad, 1st degree spasm, and there's no other pathology there, and you're not worried about their bowels generally, rectogesic. Remembering that rectogesic causes headaches in 70% of patients, and we will often prescribe nifedipine or diltiazem for them to diminish that side effect. And that works well in people who also, of course, then get bowel management advice. But if they're beyond that, or you've used it and it doesn't work, off for a decision about intervention. So there are things we can do quite effectively rather than just, oh, I've got hemorrhoids, okay, you've got hemorrhoids, we'll send you to someone to get them fixed. And the place not to send hemorrhoidal patients who actually have hemorrhoids or fissure or tags is to a gastroenterologist, because they don't look after them. They'll do an endoscopy of some sort and then say to the patient, everything's fine, you don't have cancer. No, I didn't come for cancer, I came for my bottom problem. So they need to be sent to somebody who does that sort of work. But if it sounds like it's a more proximal cause of bleeding, etc., then, and you've made your judgment, then you refer accordingly. So I'm going to spend a little bit of time on hemorrhoids just because they're terribly common and there is stuff you can do, and there are lots of options these days because, like everything else, there are new techniques, there's new equipment, and there is a bit of marketing involved in the new equipment, so we have to decide whether that's a good thing or a bad thing. First thing is that patients do not understand that everybody has hemorrhoids. Like I have a nose and 2 ears, I have hemorrhoids. Hemorrhoids are 3 bundles of veins which are superficial, therefore submucosal, just like my arteries in my hand are deep and my veins are superficial. We have blood supply in 3 terminal arteries, left lateral, right anterior, right posterior, and which are deep, penetrate, and the veins go back up submucosal before they then go out and join the mesenteric veins and up to the portal system. So we've all got them. It's a matter of how big they are. The other thing is that as I get older, the lining's coming away, my skin from my submucosa. And if I don't keep having facelifts, my face will sag as well. And that happens down below because there is a shelf at the last couple of centimetres of the rectum where the external sphincter is narrowing the beginning of the anal canal. And so there are shear forces at that point from pressure from us straining over the years to go to the loo, more so in women whose pressure is increased when they're pregnant, and also more so, of course, in people who are constipated. So this is a common problem, and clearly the major thing we have to do, apart from dealing with the symptomatology, is to ensure that bowel management is paramount, looked after, and we want a soft but bulky motion. And I mentioned before about the function of the large bowel to absorb water, move the motion along and reabsorb water. That's the snake and the water filtration plant. We want to keep some of that water back in the colon by eating the blotting paper but drinking the ink. And we do that with the fibre. If you take 2 Weet-Bix, put it in a bowl of milk and come back 10 minutes later, there's no milk. It's been absorbed into the Weet-Bix. So that's what we're trying to do in the bowel, and that's what we want to do down in the sigmoid to reduce pressure. Harder work for the muscle of the wall of the bowel, reduced muscle thickening, decreased pressure across the wall, and thus the decreased propensity to diverticular. Okay, so with straining and age, we get deterioration in the elastic tissue and the muscle support, and we get sliding of these cushions. So the bulges are covered by mucosa, and when you get that those bulges bulging into your anal canal, even if they don't become external, they will drip mucus onto the skin, hence the itch, and hence often a secondary fungal irritation. And so the treatment is the treatment of the itch and the irritation, antifungals if necessary, but that's treating the result. Treating the cause is dealing with the hemorrhoids. So there's a clinical spectrum of mucosal prolapse. I've talked about hemorrhoids, but you can actually get more of that from straining. You can get incomplete mucosal prolapse above the hemorrhoids, between the hemorrhoids. That's why we need to go back and reband areas often in 11% of people. And you can get the rectal mucosa bulging down, producing a proctitis of prolapse, Mawson's change, etc. And of course you can get full thickness prolapse and the whole pelvic floor sinking, particularly with the girls after multiple babies. So all these are a spectrum, and hemorrhoids are just the beginning of a spectrum. How do we pick mucosal prolapse from hemorrhoids, and does it matter? Not a lot. I'm interested because it's what I deal with. Hemorrhoids have a cushion, mucosal prolapse can be more diffuse. Hemorrhoids are segmental, left anterior, right posterior, right anterior. Mucosal prolapse can be circumferential, more vascular, more mucosal, glistening red, blah, blah, blah. It doesn't matter, and all those things point to me and say it's a hemorrhoid or mucosal prolapse. I've been interested because I've been trying to look at the results of management. So that is clearly mucosal prolapse. Looks nothing like a hemorrhoid. And that is, you can see the skin components there starting to bulge, right anterior, right posterior, and a bit of left lateral, pushed down by prolapsing hemorrhoids, not by mucosal prolapse. And the dentate line is just hidden in there somewhere. So that's external. It's not 4th degree because that goes back. If it was, that's 3rd degree. So we looked at injection to, the logic is if you inject into the base of the hemorrhoid 5% phenol in almond oil to help clot off the vessels. It also makes the area you're going to rubber band edematous. And if you make it edematous, you then create, a bit artificially, but 3 nice bulges. And then you are in with the proctoscope, you can easily band them because they're soft from just the edema of the sclerosant. You can pull them through into the bander and fire. And when you fire, the bands hold nicely on the neck of this pseudo-polypoid area. And this is an old series. I mean, I'm talking way back. We're over 25,000 patients now. The fascinating thing is in those 25,000 patients, the figures I'm showing you today have not altered. And I just picked this series because it's almost identical results. And we had a number of people that didn't come back for review, but pretty good follow-up. And these were the stages. And interesting, you'll see the number of people, although a small percentage, 8%, we were able to band quite a number of them. And what's this benefit of banding? The answer is we're banding the insensitive mucosa. There are no sensitive nerves. There are no heat, pain, touch, feel. There are stretch receptors in the adjacent internal sphincter. So they get a bit of pull pressure, a feeling of incomplete evacuation for a few days afterwards. But they don't have pain if you don't get the lower edge of your bands any closer than about 3 millimeters closer to the dentate line. So as long as you leave a little bit of transitional mucosa, you don't get a problem there. And I classified them into whether they were the 3 segments, majority are, or anterior only. Anterior occur because if you take a cross-section through us with a circular saw, look at one half of me, the puborectalis section of the levator ani pulls the ano-rectal junction forward. The rectum sits in the curve of the sacrum, and then the anus goes down at an angle. That's partly to do with continence, it's important, but it's also because any internal pressure of straining in all of us, or increased pressure from pregnancy in women, is mainly on the anterior wall. So separate anterior mucosal prominence is quite common. And then it can be a bit of each, circumferential, etc. There are 2 incidences, and it's not unexpected. Look at this. Males seem to get their maximum hemorrhoids, and they were mostly hemorrhoids, at the younger age than women, who get their mucosal prominence at a later age. Women have them in their earlier ages. See here, the map goes up a little bit here, is up there, but it drops right down later because we're dealing with their mucosal prolapse up there. And that's because the women are getting a little bit of fallout and things are aging. And so their post-pregnancy banding was, that was done about there. And the males have been macho, strong-muscled, rush to the loo, strain to get it all out in 2 seconds, and they get the hemorrhoids. So they get more hemorrhoids and less mucosal prolapse, and the girls get their hemorrhoids after their deliveries, not down at a young age, but then get their mucosal prolapse later in life. Interesting. And so we can easily deal with them in large numbers, nice and simple. And so we will do, there's no enema required, we do the proctoscopy, and we'll do the sigmoidoscopy and all the things that are important, some of which you might have done or we will do. And we can do 3 pedicles at once. If there are several intermediate segments of mucosal component as well, we'll never do more than 3 at once, just to prevent significant discomfort from firing off the stretch receptors, and they get proper explanation of the way in which we're talking with you today, and check them in usually 6 to 8 weeks, and we'll show you the results. Don't use a cutout on the end of the proctoscope. Should you folk who are watching be using proctoscopes with cutouts, because I don't like the artificiality of making a hemorrhoid by the mucosa falling into it. And That's the way we do it, just a small amount of phenol in almond oil, banding over each of the 3 deformable bulges, lower edge of the bands 3 to 4 millimetres above, secondary bandings later but not at the same time. Anxious males with sphincter spasm are a problem. They jump off the bed, they're infrequent. Once a girl's had a couple of babies, she'll just lie there and let you do it, so it's much easier. Suction banding has been used in recent years. I don't like it. It's a machine which you put the suction bander onto the area you want to band. It sucks an amount of mucosa into the end of the instrument, and then you fire bands. I like to judge the exact amount of mucosa I want to pull in, and I can do that just with the banding forceps pulling. I prefer to do it with the manual sterilised equipment, just to know I've got exactly the amount of tissue I want to get in exactly the area that I want to get. I think, without having done a double-blind randomised controlled trial, which I have no intention of doing, I think I am subjected, or my patients are subjected to a lower incidence of need for secondary and subsequent further banding. So they're looking with a colonoscope in the bowel rotated from the upper part of the rectum looking down are the sort of bulges that we'd be dealing with, and there they are seen through a proctoscope, and that looks big, but that goes into, that's actually 2 there, that's the right anterior, that's the left lateral. There's a little tiny secondary bit, leave that for now, if not, in fact not at all, and not do anything at all, and that is the right posterior. And they're beautifully banded and they're big, and they would, when I was a registrar, we would be operating on all of those, and of course the operation consists not only of the transanal surgical excision, but the skin component as well. And the beauty is that doing this is like doing a facelift. When the plastic surgeons do a facelift, they cut the skin out here and then pull this back. Imagine this is the skin component externally, and this is the hemorrhoid. They get rid of the hemorrhoid, but they draw this back, and there's nothing here. And the same thing happens. When you do the banding, you are taking a broad fold, banding it, pulling the lower edge up and the upper edge down, but by pulling the lower edge up, you're also hitching the dentate line. So it effaces, and in most people, removes the bulging skin component. So it works well in most people. And there are those segments already banded. And there is again looking at the banded segments with the scope in from above. And you can see the nice mucosa between them there. It's the only spot you can see it, where it's all nicely taut now, T-A-U-T, and fine. No banding, a number of patients. Well, sometimes patients don't want to be banded, thank you very much. Sometimes they don't need to be banded, minimal problems. Some get sclerotherapy alone. I'm going overseas in 10 days, doctor. I won't band. Overseas meaning a long flight. I don't mind them going to Melbourne. The sheet of information has a paragraph in it of telling the local intern of the emergency department how to fix a secondary bleed, which occurs anywhere between 10 and 20 days. Late, interestingly, because the tissue is dead in 6 hours, irretrievably. It's immediately ischemic, it's necrotic in 6 hours, and it's all gone sometime after 2 to 4 days. So we ask them not to strain, to ignore that third feeling of a bowel motion. What do we do when we go to the loo? We feel the pressure in our belly. That's our sigmoid. We empty our sigmoid, we empty our rectum, so we get rid of our abdominal symptom, our upper back passage symptom, and then we squeeze at the anus. And virtually no patient I've ever spoken to has thought about that, but that's what we all do. And what you're doing then is removing any bowel motion that's left in that last 2 centimetres of narrow rectum above the dentate line to inform us, because it stretches the wall there easily, by stretch receptors in the internal sphincter, there's a bit more to pass. We push, squeeze it, get rid of that, and we clean our anus. So there's not much cleaning up that we then have to do. So I asked them not to do step 3. Once you've had a reasonable motion, please keep your bowels free and easy. Make sure, and it's all on the printed sheet, make sure you empty sensibly without straining, because I don't want you to force the bands off. So please ignore that last bit of feeling, because you can't tell the difference between a bit of motion or the dragging from the bands. So the message of importance is that last line. You don't want to force the bands off prematurely. In 2 to 4 days, you'll be sitting on the loo and you'll think, oh, I feel empty in the anus today for the first time. That's when you'll know they've gone. Thereafter, all you've got are 3 little scabs. But it's curious that the secondary bleed rate of 0.48%, but that's nearly 0.5, which is nearly 1 in 200, occurs. A secondary bleed may stop spontaneously, the vast majority do. The management is simple. Emergency department, instruction sheet for the young emergency doctor at 3 o'clock in the morning who has not an idea what to do. Last thing you do is put a proctoscope in. The only thing you do is put a Foley's catheter in with a balloon, blow it up, put traction on it and strap it to the thigh under gentle traction and leave it for 12 hours, let it down. And that stops the bleed. There are some patients who have such big hemorrhoids or are 4th degree incarcerated, they need an immediate hemorrhoidectomy, or they're unsuitable for banding, and they will have surgery. And there are complicating factors, and they're people with immune diseases, bleeding disorders, who are on and are not allowed off their anticoagulants because of major cardiac reasons or whatever. Those patients, we did a small study on them years ago because nor were they suitable really for surgery. So we did a controlled trial of surgery versus nothing versus banding. The banding rate, instead of being 1 in 200, was 30% in the few we did. We stopped, obviously. Surgery we would only do if they could come off their medications appropriately, and the others we can treat by sclerotherapy, which is not nearly as effective as banding. It's only temporising, as might it be for the patient that is going overseas, to get back to my earlier point. And we'll say, when you get back, we'll sclerotherapy now, that might tide you over while you're away, and when you come back, we'll band you. Complications, pain prevention by avoiding being close to the dentate lines. Other anorectal pathology, do not band hemorrhoids when there is a concomitant fissure. Get the fissure fixed first, either conservatively or operatively, and then fix the hemorrhoids. If one is doing it operatively, we can band the hemorrhoids at that same procedure because they've got a relaxed sphincter after the minimal sphincterotomy performed to relax their sphincter without causing them any incontinence. I've had some weird things, clearly with doing so many over the years. A prolapsed hemorrhoid that was banded, that clearly had to be dealt with surgically. Occasionally we'll see a perianal hematoma, and I'll think it's a separate thing, but given that they occur in temporal proximity to the banding, probably due to interference of the venous anastomosis between the portal venous system and the peripheral venous system at the anal verge, and therefore it's probably causative. Deal with the perianal hematoma, local anaesthetic incision and evacuation. Local sepsis, septicemia on 2 patients, both of whom had had colonoscopies. You can cause a bacteremia at colonoscopy. Both of them were cardiac patients. Both of them had been given prophylactic antibiotics because they were having a colonoscopy and had cardiac valve problems. So we didn't win there. We had no deaths. And bleeding, as I've mentioned, and that's it. The results, pretty good. They're the sort of minor symptoms that remain. Significant pain, rare as rare now. This was in our first 4,000. We're better at it now. It's very rare to get pain. Hemorrhage, there you are, 0.5%, close enough. And 93% of our patients were dealt with, excuse me, sorry, 93% of our patients were dealt with by banding hemorrhoid patients who had only that, no other pathology. The other 7% have been dealt with by more major intervention because they needed it. And it's interesting, we've gone from pretty much 100% of patients who warranted surgery going down now to only about 7%. So it's not an operation, fortunately, we need to do now very often. And here are the episodes of recurrence, 1, 2, 3, 4. Most of the recurrent bandings have been in people who are women who've had recurrent incomplete mucosal prolapse and were not suitable, did not want, or did not require surgical intervention of more major type. So pretty good. And 89% then have come back first pass and have said they're fine. 11% had needed further intervention. 6.4% and then 2.4% overall. So it works pretty well. But I guess the summary of all of this is that most of the time I think we can work out what our patient has, and then this will help us both in assessment, decision making for your management, for your patient, and also help you with decisions about if, to whom and when to refer. Thank you very much. I hope that's of some help.